Hi everyone, welcome back to Psychiatry Network. This is our third journal club, and I am about to request Dr. Pittman to join us. How's everyone doing tonight? Tonight we are going to hear about, the title of our article is The Role of Behavioral Interventions in Buprenorphine Maintenance Treatment, a Review. So that's what we're going to be talking about tonight. So buprenorphine, I know, is something everybody is always a little bit nervous about. Like I know in my department, for example, I think Dr. Pittman's joining us, but I think in my department, there's only a few of us that are Suboxone certified, and that I think is nervous about prescribing it and what that means. So we're gonna just get more. Here, sorry.
A little feedback.
Is that better?
Is that better?
Yes.
No.
Okay.
Yes.
Can you hear me?
Can you hear me okay?
Yes, I can.
Okay.
Okay.
So I
have.
Hi, Rhoda.
Hi, Rhoda. I wanted to read Pittman's bio.
You know, I'm not
really sure.
Hang on
one sec.
Move
Move the camera.
Okay. Sorry for the technical. All right, so
Dr. Pittman
grew up in the DFW area. Graduate degree
in University
at Austin.
Completed science PhD
At the University of Texas. With focus on the behavioral process of drug addiction. Hence, you're doing an addiction topic. So she completed Harvard Medical School, Massachusetts Hospital, McLean Hospital Psychiatry Residency Training Program in Boston, where she served as chief resident
in addiction her year.
Then came to Texas to complete her addiction psychiatry fellowship at the University of Texas Dallas. She has been in private practice in the DFW since 2001. Also provides additional psychiatric and adolescent residency. And on the director or Nexus Center until she becomes director. She's currently on active. She's board certified and addiction and medicine. So thank you for sending this article. I will let you take.
Okay. I hope everyone can hear me okay. Thank you so much for having me. I chose this article because it's very germane to what I do
Speak just a little bit louder.
You got it. So I chose this article because it's germane to what I do pretty much every day of the week. I do buprenorphine maintenance in my private practice and in group therapy in the residential treatment facility where I'm medical director. So I was actually trained by Roger Weiss, who is lovely and amazing, and the paper is really, really good. So it was written by Kathleen Carroll, who's a PhD from Yale, and Roger Weiss, MD, who runs the alcohol and treatment program at McLean Hospital at Harvard Medical School. So we know that counseling is a required part of the office-based buprenorphine treatment, but the nature that constitute effective counseling is still unclear and controversial. So in the DATA Act, the Drug Abuse Treatment Act of 2000, which is the literal act of Congress that was required to get physicians to write outpatient maintenance therapy for opiate addiction, there is a statement that requires physicians who write buprenorphine in office-based practice saying that they must have the capacity to refer patients for appropriate counseling and other appropriate ancillary services. But even after 18 years, we don't really know what appropriate ancillary services means. So Doctors Carroll and Weiss went to look through the existing literature for the nature of the role, intensity of behavioral interventions that are being provided in office-based buprenorphine treatment to see if we can get some sort of consensus on what helps, what works, what makes sense. And what they found was that there were 4 high-quality studies that had no additional benefit of behavioral counseling, and 4 studies that were high quality that had a little bit of benefit of additional therapy. And so what they did was they sort of went through those, and I'll talk about, they did a really good job of distilling the characteristics that distinguish the studies one from another. I'm not going to go through all 8 studies because we do not have time for that. But what I will do is sort of distill what they talked about in a way that I think that we can actually go forward with and use. So the questions that they came up with is they had 6 questions. And the first one, so the question was, is buprenorphine really just that effective? So there's no question that buprenorphine maintenance treatment is far more effective than any intervention that does not involve an approved medication for opiate use disorder. So we know that there's a 7-fold increase in successful outcomes with maintenance with buprenorphine versus putting the patient on buprenorphine with a quick taper. And there's about a 6% retention rate without any medication at all. So that's 94% relapse. So we know that the buprenorphine itself in maintenance treatment has a retention rate about 50%. It's actually 49%. So we round that up to 50. So you want to remember that buprenorphine has a 6-month retention rate of about 50%, which, you know, is way better than 6%, but methadone's retention rate is about 75%. So we know that methadone holds people more effectively, and I think part of that is because of the way methadone is distributed in the United States. We really only give methadone for opiate use disorder out of federally licensed methadone clinics, which is essentially at the beginning daily dosing. So they come Monday through Saturday with a take-home on Sunday, and they do that for at least 6 months before they ever get a single take-home. So it is much more intensive treatment than some of the office-based buprenorphine treatment that's out there. We also, when they went in to look at the methadone studies that are out there, we know that the better outcomes actually come from methadone clinics with more intensive interventions. So the less intense interventions, interventionist kind of programs with methadone don't have that 75% retention rate. So the goal here is to look for factors that could increase the retention rate with buprenorphine in office-based practice. So when they did that, they looked at these 4 positive and 4 negative studies. So the next question they asked was, is medication management really that effective? So in the 4 studies that had negative results, so they showed no additional benefit of therapy over medication management, it's thought that the level of care in the medical management group represented an adequate level of treatment for many patients. So the therapies that they tried were counseling, CBT, and contingency management, but they were all in combination with this intensive medical management group. And what that means is essentially, it's the way I practice buprenorphine, the way I was trained. Not everybody does it this way, but it's essentially, you know, it involves regular appointments with a physician, who then assesses the participants' progress, medication efficacy, and side effects, and consistently stresses the importance of abstinence and benefits of attending mutual self-help programs, so NA or AA. Also associated, at least at the beginning, with weekly tox screens. So when I put someone on buprenorphine who's actively using, they come and see me weekly. And that's considered high-quality medication management. So when they talk about these 4 studies with that weekly check-in with the doctor, they talk about, you know, how the behavioral management or the behavioral interventions, the therapy that they tried didn't really help much on top of that. But they thought maybe that it highlights the potential powerful influence of the physician's involvement in patient outcomes. So the other difference between these studies and the ones that had an effective therapy is that with the high-quality med management, it turns out that the doses of buprenorphine that were allowable inside the study were actually higher. So they allowed people to go up to 24 to 32 milligrams, which is a fairly high dose of buprenorphine. So that kind of opened my eyes, because I'm kind of nervous still to go past 16, because I kind of feel like I'm just supplying them with stuff they can sell on the street, which makes me monstrously uncomfortable. So I think maybe I have some learning to do, but that's okay. That's what this is for. So the next question they went on to is, are the behavioral interventions that we looked at just ineffective in this population? So in the 4 studies that did show an additional benefit of behavioral intervention and buprenorphine maintenance, the only effective therapeutic approaches that they could find and replicate were contingency management. So I don't know if y'all know what contingency management is, but in a drug abuse model, it really is essentially paying addicts for negative urines. So it's usually a financial reward. Sometimes there are vouchers, like in our rehab facility, they'll give like the adolescents vouchers for like to get something out of a glass case, and they put it in a see-through case, so it's like tantalizing, but it's like purses and little sewing kits and tchotchkes. So we have a women's treatment facility. That's what that so it's essentially cosmetics. But in these studies, all 4 of them had escalating monetary rewards for consecutive negative drug urine screen or urine toxicology screens. And so the benefit was shown to be most robust in contingency management, with escalating rewards, and the benefit actually disappeared when the rewards disappeared. So the difference between these studies and the ones that didn't show any benefit of therapy was that none of these studies utilized that intensive medication management model. The other difference was that these studies had a high or a lower buprenorphine allowable dose, with the max really coming in between 16 and 18 milligrams. And so there's a question about, does dose make a difference? And I think the answer is probably a resounding yes. So the other study, or the other questions they really talk about, it was whether the research design of the studies had an effect, and it really, I think it probably did, in that none of the behavioral interventions were tested with, none of the effective behavioral interventions were tested with the high quality med management. Also, there's a high dropout rate with drug addicts. And usually most studies actually call a dropout a treatment failure, but there's probably an inherent bias in that it's probably not all treatment failure, so it makes it difficult. So they asked a bunch of questions about what's needed to go forward. I'm going to go through that quickly and then talk about what we want to do from here, because we've got a little bit of time, but I want to make sure we cover that last point. So the second to the last question was, what do we know about subgroups of patients who do and do not seem to benefit from behavioral interventions? And the answer was not a lot. So we need more data on what types of individuals do best in which types of programs, office-based med management versus inpatient versus other higher levels of care, say intensive outpatient or IOP, other kinds of step down. There's an interest in the rates of mutual self-help group attendance in buprenorphine maintenance patients, and information on what their experiences tend to be like. So do these people actually go to AA and NA? And if they do, what's it like for them? And I can shed a little bit of light on that anecdotally, in that my patients tend to be terribly ostracized when they try to go to self-help groups for being actively using. And they maybe haven't touched heroin in 10 years, but they're still on buprenorphine. And so I actually ask them to play their medications pretty close to the chest, because people have an opinion on Prozac and buprenorphine, maybe not so much lisinopril, but they really don't have any more information about Prozac and buprenorphine than they do about lisinopril. So I have them say a little mantra inside their head, like, where'd you go to med school? Not out loud, but silently, and it helps a little bit to give them a little bit more oomph. We need some more information about outcome studies on the stepped care model versus fixed care, so everyone gets the same thing versus we're kind of stepping people up as they do or do not do well. Interested in what innovative approaches might be put in place to increase retention and treatment with the buprenorphine maintenance group, because 50% is a lot better than 6, but it sucks compared to 75. So we kind of want that methadone retention. The relationship between buprenorphine dose and patient outcome, I think, is a critical place that needs some additional research and funding. So a lot of people are afraid actually to write those higher doses, that it's diversionary. So And then we want to figure out the optimal models to make improvement and overall function optimized. So what do we do with this information? Like, where do we go from here? Because it's a little bit, I don't know. But what clinicians should aim for in terms of buprenorphine maintenance treatment is actually pretty simple, and pretty much what Dr. Weiss taught me and how he taught me to do it, which is nice. So we really kind of want to do an individualized program like we do in the rest of psychiatry. It's actually not rocket science. So start those patients who are appropriate for office-based treatment at a level that's acceptable to them, because what you're trying to do is get them to come back, and that's the number one goal. If you can get them into that stepped care model where patients start at a relatively low intensity treatment and only step up if they start to fail treatment, bring in negative or positive urines, or struggle early, then you can actually step them up into a higher level of care. Patients are much more likely to engage. The aims are twofold. We're aiming for retention in treatment. Like all of psychiatry, patients do better when they come back. So you want them to come back. That's really the first goal. The second goal is to produce negative urine drug screens. So if you can bring them in and get them starting to pee positive, they start getting really excited and they're like, I can pee, and it's fun. And so patients get really, really excited about how easy buprenorphine makes things, and how they don't have to struggle quite as hard as they did before. So I believe that is 7:45. So that went really fast.
Thank you so much.
You're welcome. It was my pleasure.
Yeah,
And
anybody
has any questions,
ask them,
and
we are
we
going
are going to wrap up.
And
I did
specific
direct
access
access the seat
in the top of the post.
in the top of the post.
Okay, awesome.
See you guys.
Thank you.
See you.